Hey everyone, and welcome to week 6 of the rolling teaching program for sickle cell disease. For those of you who don't know me, my name is Christopher Dean, and I am the red cell nurse specialist for pediatrics here at UCLH. I'm also the lead nurse for training and education for our network. Before I hand over to your speaker this week, I would like to go over the learning objectives for this session, which is entitled Basic Nursing Care. For those with sickle cell disease. So the learning objectives includes that the candidate will gain an understanding of the basic nursing care required for our service users admitted to the inpatient wards. Candidates will better understand the signs of a deteriorating patient with sickle cell disease. And then finally, candidates will be aware of the appropriate monitoring required for inpatients with sickle cell disease and to be able to escalate accordingly. I'm going to hand you over to Olivia now.
Right, so hello everyone, my name is Olivia and I'm the sickle cell nurse specialist for adults here at Whittington Hospital. So today we're briefly going to be talking about basic nursing care for sickle cell patients when they present to us, things we should be looking out for, and obviously if the patient deteriorates as well. If you have any questions, just put your hands up. I can't see on the screen, but just put your hands up, and then whoever can see it can just let me know, and then we can answer the questions from there, as well as the questions at the end of this teaching. All right. So today's topic, we're going to discuss our 4 things. So it's monitoring of the patients, analgesia, fluid balance, and then sign of deterioration. So firstly, let us look at what is a nurse. There was so much definitions, to be honest, when I was actually looking for what is a nurse, but I think these two really do sum up basically what we do on our daily practice. So nurses act as a patient advocate, keep patients comfortable, prevent them spread of disease, and provide ongoing care. Nursing encompasses autonomous and collaborative care of individuals of all ages, families, groups, and communities, sick or well, and in all settings. It includes the promotion of health, the prevention of illness, and the care of the ill, disabled, and dying people. So these 2 definitions from WHO, 2022 actually, very current. And basically it talks about what our daily practice should be as nurses. We're not just there to only care, we are there to care for the patient. I mean, that's why we are nurses, but it also surpasses more than that. We're there as probably like the last line of defense for our patients. So our role is very, very vital. So here I'm going to talk about what we use as our daily practice. And this cycle shows basically what we call the nursing process. So the nursing process was discovered in the 1970s, if I'm correct. And this talks about basically about what we do on everyday practice, whether in the community or in the acute. So the first one you can see here is talk about assessment. So assessment's got to do with the patient, from our physical observations of the patient. Are the treatment that they're having, is it okay? Is there anything that is different on our shift today, for example? And then the second one will be the nursing diagnosis. So we can use here as sickle cell, the most prevalent thing that patients come into hospital for is obviously pain. So if you see your patient is in a lot of pain than usual, that will be your first assessment. Your second is your diagnosis. Okay, fine. This patient is definitely in pain. So therefore, how do I address the pain needs? We already know that the patient has medication for pain relief, but then obviously the pain is even more increased today. So then we start planning and thinking, right, do I need to see what they have on their chart? Is there anything additional that the doctors have written up for them? So we start planning and trying to achieve what we assess for the patient. And then it goes into nursing intervention. So here it talks about direct care, teaching, counseling, and coordination, but I should also talk about what we are doing to implement the change that we need to make for this patient. So for example, if you're giving the patient pain relief that they have other ones as well, which are normally given as a regular, and obviously you're given PRN, and then still the pain is not controlled or adequately controlled. And then we have to say, fine, we need to contact the doctor or the SHO and let them know this patient is in more pain today on my shift, and I would like you to review it. So therefore the doctor will come down and review the patient. Once the doctor has reviewed the patient, and obviously it shows that he needs to increase the pain medication that he's given the sickle cell patient, then we evaluate after a while, has that helped the patient? Are they still requiring more pain relief? Do I need to alert the doctors back again? So we go to this constant cycle every single day as we are nurses to make sure that obviously our patient is kept comfortable. Are we achieving the care that we're supposed to achieve, or the clinical outcome for them is to get better? So this is just a little bit of summary of what we do on our day-to-day practice. Right, so let's start with monitoring. So most common presentation of patients with sickle cell disease is vaso-occlusive crisis. So I know we've talked about this, Chris has talked about this in previous sessions with us. So most of the patients that come in on the adult side come in with mostly about 90% of them come in with pain. So when these patients come in with a vaso-occlusive crisis or a sickle cell crisis, it's either one or the two that they normally use. Then the most important thing is that what are the observations that need to be carried out for these patients? So one thing we're looking for when we're observing these patients, when they're coming with a vaso-occlusive crisis, is one, assessing pain medication prescribed. Is it effective? Two, early detection of deterioration. So are there things other than a vaso-occlusive crisis that is going on here for these patients that we can obviously see in their vital signs, for example, that then yes, we need to act promptly. And three is a baseline of recognizing complications as well. Because most patients, most of them, as I say, present with a vaso-occlusive crisis. But if the patient starts to get worse or starts to deteriorate, or there's something which is new, then definitely we will see in our observations with these patients as an initial stage. So the most common tool used is the new score, which is called the National Early Warning Score. And I have a picture of that, which I'll show you in later slides. So we're talking about observations or using the new score that all of us use in our trust. So when we're monitoring sickle cell patients or who are in crisis, what exactly are we looking at to make sure we haven't missed anything, or if there's something that we see early that we need to act upon? So the first one will be their blood pressure baseline. So once patient presents from ED, for example, and comes to the ward, sometimes patients in their first 24 hours or their first 48 hours, if they're having pains in their arms or the legs, then obviously we don't want to do blood pressure, which also induces their pain even more. So it's very important that you also have good communication with your patient here to express, okay, fine, we just need to do a baseline observations or BP, blood pressure on you, just to know basically, are you all right? Is anything we need to act upon? And I think once a baseline is done in A&E, and then when they come to the ward and we do another baseline as well, we don't need to do, because I know we obviously do every 4 hours as the new score may say that we have to do. But at times as well, with our patients, if we are presented, for example, with pain in their arms and their legs, we don't really need to do it less frequently. So I wouldn't really advocate for us to do blood pressure less, 4 hours or every 6 hours. I would say if we have at least about 2 a day, then that's okay. But if the patient deteriorates, then definitely we need to increase the amount of times we do the blood pressure. And then we're looking at oxygen saturation on air. So is the patient within their range? If not, what will be the query or what will be the cause of this? So when patients come in with their oxygen saturation, for example, on their patient key record, we normally have the observations which are in their normal baseline when they're in outpatient clinic. So if they come in and they're quite unwell, they're having a vaso-occlusive crisis, for example, and then the oxygen saturation goes down. Let's say their baseline is 95, and then it goes down to when they're coming in about 89 or 90. then we can see that, yes, there's something definitely going on here with this patient. This patient has deteriorated. So here we have to look, is the patient's having a chest crisis, or are they having what we call pulmonary embolism? So it's very important that patients, regardless if they're on oxygen or not, I always say that we must do the observations off and on oxygen. Because the first thing, if a patient is deteriorating and they're having acute chest crisis or a PE, for example, one of the first things you see in the observations is that obviously the deterioration of their oxygen level. Again, is their respiratory rate high or low? So the reason why I put here query cause is that respiratory rate can show two things for our sickle cell patients. One, if it's too high, it can show that, yes, there is probably more use of the accessory muscle. They're breathing above 20 beats per minute. If they're like 25, 26, 27, that also shows that this patient is also deteriorating as well. So then obviously within our new score, you see that score go higher. That tells you that, yes, we need to tell the doctor to come review this patient urgently. Also as well, there's also low respiratory rate. The reason why I put that there is because patients, especially sickle cell patients, they're on constant pain relief regularly, more than the average of patients that are in hospital anyway. And one of the side effects of the pain relief that we're giving to our patient, it can lower the respiratory rate. So in trust, some people say if their respiratory rate is less than 10, then we need to stop and review their pain medication. Some trusts say 8, some trusts say 12. But here at the Whittington, we say if it's less than 10, then obviously we need to stop the opiates, give them naloxone, and then obviously review the pain medication we're giving them. So that's the reason why I've put high and low. So we have to know the two and know exactly how we act upon that as well. And then we talk about sedation score. So this again has got to do with the pain medication we're giving to our patients. Are they alert? Are they drowsy? Are they did they respond to you when you tap them or gently on their arms? Or if you call their name, do they respond? It's very important that sedation score is also checked as well when we're doing observations for these patients. Again, it's because of the pain relief that we're giving them, which can, another side effect of it is obviously it can make them drowsy. So we need to make sure that obviously we are giving our patients pain relief, but we have to also make sure that we are also giving them something that is not also, again, giving them harm. So we have to find the right balance for pain relief for our patients. The next one will be the pulse rate. So this again will obviously go high if the patient's pain is not adequately controlled. So definitely we'll see that they're going about 100 or so more high. Temperature, this also shows infection, for example. So if the temperature is above 38, then we normally just do our blood cultures, we do our bloods, we let the doctor know. So obviously we need to have the patient straight away on IV antibiotics. And because most of our patients who have sickle cell disease have their spleen removed at an early age, we have a very low threshold for IV antibiotics. So we give that straight away regardless. So the temperature can also show that obviously there's an infection going on. Also is when we have to look at the pain score as well on that observation chart. This also shows if the pain is controlled. Are there any changes that needed to be made? Earlier on, I talked about the nursing process and I talked about when we're assessing, planning, evaluating, implementing care. This again comes into this, for example. Is their pain controlled? Is there any changes? Do we need to increase the pain medication that we're giving to the patient? Do we need to add anything that we need to give to the patient? Obviously, you converse this with the doctor. But again, this also shows as well for us as well, if we're actually, achieving the goal, which is to get them better. And then also I put here delirium and confusion. So some patients do come into hospital and as I said, 90% is a vaso-occlusive crisis, but we do get some who come in as well who are not really coming in with pain. Some of them are coming in with delirium or confusion. And in this case, if they're coming in with that, then this is probably an indication that the patient is actually having sepsis. So obviously, again, we need to act quick. So these are the things that we need to look at when we're monitoring our patients who have sickle cell crisis or sickle cell disease patients in general. All these things tells us if we're going on the right way or the wrong way with the patient as well. And obviously, we need to act fast on all these things. So here I was talking about the new score. So this is the one that we use in our hospital, and I think it's generally used everywhere anyway. Some people may have a little bit different ones, but this is the general one that we normally use. Can you guys see this more clearly? The new score is all right?
Yes.
Yeah, that's good.
Yes.
Thank you, Amina. Yeah. So generally we use this, which is called the new score, and this obviously shows the markers if your patient is deteriorating. So for example, if it's a green 1 to 4, then that means we still have to continue observations if it's every 4 to 6 hourly. If it's going to the amber phase, then that means that definitely that obviously we need to increase. Maybe this patient is obviously signs of deterioration, which we need to act fast on. And if it's in this color, which is the orange color, then that definitely means that this patient is a very, like basically the shared care with the critical outreach team. Let me admit somebody, the critical outreach team. So therefore we have to make sure and ensure that obviously as we're following these signs as well, the higher it is, the more the patient is deteriorating, the more we need to act fast. Right. Right, we're going to go to our next one, which has got to do with analgesia. So this is a generic Q analgesic ladder that is used worldwide in patients when we're managing pain management as well. So you can see here, step 1, we start with obviously a non-opiate. So most of our patients are on paracetamol at home, dihydrocodeine, ibuprofen, codeine phosphate. So once they come into hospital, it's very important that that is added to their regular medications. And then obviously they're coming in because the pain is obviously not controlled, but then probably we'll add what they put here, which is codeine, dihydrocodeine. So the first one, non-opiate, is paracetamol and ibuprofen. And then the second one here you can see is codeine, and we go into dihydrocodeine and so forth. And then the third one is when we have the morphine, oxycodone, the fentanyl. We also have the other one is diamorphine as well, which we don't normally use. So these are the 3 steps into trying to achieve good, adequate pain control for our patients. So this is just a generic thing that everybody uses for pain management. So here we talk about more in terms of our patients. So the common use medications that we use for sickle cell patients. So we mostly use first line now is morphine. There's some patients who used to be on diamorphine, and now that's a natural shortage, so we've stopped that completely. So we've converted all our patients who use diamorphine on morphine. Although at times, sometimes we do have, it's a hit or miss anyway, but we do have sometimes stock on diamorphine. So if we do, then we tend to, negotiate with the patient that this is what's going on. We have a shortage of diamorphine. If there are any that we could, then definitely we do give it to them. We don't stop that here at the Whittington, but mostly we use our patients on morphine anyway because it's quite rare we get stock. But if we do, obviously we negotiate that with the patient. And then we have fentanyl as well. So we use normally fentanyls in PCAs, but I'll go into that when I go into PCA. We have codeine, as I said, dihydrocodeine as well, which is also patients should be on the regular charts anyway. And then we have tramadol, paracetamol, ibuprofen. I put here ketamine because I do have a few patients here at the Whittington. I'm not sure about other people's trusts, but we do have a few patients who are very hard to manage their pain control. And sometimes ketamine is used, but it's only used when the patient is in ITU. I mean, we have one patient who's on ketamine, and she also has to go on ITU for that anyway, for close observations and monitoring. And then obviously, as I said, because we're giving this pain medication regularly, whether it be subcut, whether it be IM, whether it be a PCA, the most common things of us as nurses to make sure that we deal with the side effects. So obviously we write antiemetics because the side effects of these medications are nausea and vomiting, but under no circumstances do we give our patients any IV cyclizine because in the past, some patients in a way do get a high on it. So just to cut it out, we don't give our patients any IV cyclizine. Also as well, constipation is also a side effect of the pain medications that we use as well. So it's very important that they have laxatives written up. Obviously, as I said earlier on, respiratory depression. So because our patients are on a regular regime of strong opiates as well, it can suppress their respiratory rate. So it's very important, as I said, if it goes below 12, or some people in their trust are 10, or some people are even 8, that obviously we have to review properly the pain relief we're giving them. Fluid retention as well. So some of the side effects of these strong opiates, such as morphine, oxycodone, diamorphine, is that it can cause fluid retention. So this is where the patient hasn't passed urine for the past maybe 4 to 6 hours. Then we have to do obviously a scan of their stomach, and we found that some patients are retaining about 800 mils or so, 800 milliliters or so. So therefore, this person needs to be obviously catheterized, and that because obviously the buildup of this fluid retention can cause toxicity, which is also harmful for the patients as well. Itchiness, as with most of these strong opiates, the patient will become itchy, so we need to give them an antipyretic. So this will be your Piriton, or some people are on promethazine as well, additional as well. And then we talk about sedation as well. That's also the side effects with these strong opiates as well. So as nurses as well, with our news chart, we also need to monitor, are they alert? Are they drowsy? And if they are drowsy or a little bit unresponsive, then we need to act fast and try and, stop their medication and review it. And then obviously their pain score as well. And here, this is here because obviously we have to make sure that is the patient achieving their pain management? Are we achieving it? Are their pain is getting better, or is it getting worse as well? So when these patients, as I said, on regular medications like this, it's very important for these points as well for us to, as nurses, look upon. Because if anything goes wrong, you normally see in these kind of observations as well as their clinical observations, which is their BP, temperature, and so forth. So here, when we're assessing our patients as well, this can not only be for nurses, healthcare assistants as well help us do our observations. So we have a pain assessment tool, which is very important. Here we use 0 to 3. So we ask them, 0 will be no pain, 1 will be some kind of pain, 2 will be moderate pain, and 3 will be severe pain. But in the pediatrics, they tend to use this, and they tend to use the scale of 1 to 10. So obviously they can tell us if the pain is getting better or if it's getting worse. So these are the kind of tools that we use here. But in the winter, we only use 0 to 3. We don't have this one, but this one is in the pediatrics. This one, which is the 0 to 10 as well, we don't normally use this, but these are also used somewhere else as well. But it's all the same principle anyway. It's just to ask for know if the patient's pain is being achieved or not. Some adult patients as well. I mean, some of our patients as well, sometimes as well do respond better to the pain assessment tool that they use in pediatrics, especially the ones who have learning difficulties. So sometimes as well, they also find this quite useful. I find it quite useful than to use the 0 to 3, because sometimes the patient can be telling you that for learning difficulties, one of my patients, they were telling me that, oh, my pain is, 2. But then I could see from the chart that he was using it regularly, and he was having more signs of pain. But because he has learning difficulties, maybe he couldn't express that, or maybe the nurse will ask him, and it was a miscommunication. So sometimes I do use this tool as well for patients like that as well. And then apart from pain medication as well, I think the other thing we need to know as nurses as well is that when we're managing pain in sickle cell patients, it's not only our medications that we're given, but it's also important that we also use non-pharmacological interventions. So I know that Chris talked about in his earlier teachings about incentive spirometer. So this is mostly used to minimize chest complications and prevent chest crisis. So this is normally used very well for patients who have an acute chest syndrome or who have a chest crisis as well. So what they do is they have to blow into this machine about, we say 10 breaths every hour or 10 breaths every 1 to 2 hours anyway. And it's very important that when you're encouraging patients to actually do the incentive spirometer, it's important that we get their pain controlled. You're definitely not going to get a patient who's got a lot of pain in their chest to do incentive spirometer. So it's very important that we give them sometimes pain relief first before we actually encourage them to do the incentive spirometer. So that's a good food for thought. Also as well, it provides increased good airflow within the patient's lungs, especially if the patient is bedbound as well. So the reasons that we use this are for back pain, chest infection, reduced oxygen saturation, and sickle cell patients who come out of post-op as well. So this is a very, very good tool actually, and it does really, really help to allow airflow into the lungs for our patients. And then other non-pharmacological interventions that we use for our patients as well are heat pads. So you can see here, this is what we use in our trust. This is a TheraFlex. So this heat pad as well is very good. It's also used as distraction as well. I know they use it in pediatrics as well as adults here. And it has a very soothing effect when applied to the area of pain. So we normally put this in the microwave for about 1 minute, 30 seconds. Then we put a pillowcase and wrap it around it. And then this in turn helps the patient with their pain. So it's very good. Some patients find it, sorry, I'm teaching. Sorry about that. Some patients find it very, very effective. So I would encourage as well that when we are on shift with our patients as well, is we ask them, oh, what other things do you feel helps you with your pain? I mean, apart from a sensibar, which can give them also a heat pad as well. Some of them may also listen to music. Some of them may also find watching stuff on their phone as a distraction. It can be all sorts of things. So I do really encourage that as well. And also as well, we have some few patients who use balms as well. So these balms I've seen some of our patients, mostly the ones who come from Afro-Caribbean, which is mostly Ghanaians, Nigerians, and those from the Caribbean as well, use these heat rubs. They are very, very hot, to be honest. So sometimes some patients do find it very, very helpful. So I also do encourage it as well. It's mostly a natural thing anyway. There's nothing that contraindicates in it with the pain medication that we're giving our patients. So I do advocate it's very important that if they also have these as well, and then you need help applying it, I would say, yeah, let them apply it. It's very good as well. I mean, some people have don't have sickle cell disease and have back pain, and they find these balms very, very helpful as well. So these are the kind of things that some of our patients will use as well to try and help them with their pain when they're in hospital. And then we're going to talk about another thing, which is patients PCA. So patient-controlled, analgesia or nurse-controlled analgesia. So mostly these are used when we first of all give our patients either be the oral morph or be the injection route, and that's not helping. As I said, we assess our patients day by day to see how their pain is going, and sometimes some patients do need PCA. So these are used for patients who are critically unwell, unable to manage their pain with subcut or intravascular injections. Nurse-controlled analgesia is mostly used in ITU for the patients who are intubated and are responsive. So they tend to have nurse-controlled analgesia there. Medication used are mostly morphine, oxycodone, fentanyl, and I said plus or minus ketamine, depending on your patients as well. Every patient has an individualized care protocol. So some patients, or one or two of them, which is quite rare, do need ketamine to control their pain. But those patients are quite the ones who are quite complicated, who have very complicated pain management anyway. So it's mostly given subcut or it's given intravenously. Those are the two routes for PCA. And here at the Whittington, for those who are on subcut PCA, they tend to have a bolus dose between 1 to 10 over 10 minutes. If a background is needed, then the patient will be nursed definitely in ITU or hematology ward as well. And we have to closely monitor these patients who are on background PCAs as well, because I said that one of the side effects of the medications that we're given as morphine, diamorphine, oxycodone, or fentanyl is respiratory depression. So we have to obviously monitor them more closely. A pain assessment chart should definitely be implemented with these patients on PCA or nurse-controlled analgesia as well. Or even if they're not on PCA, I think pain assessments should always be put in place for sickle cell patients, because you should be reviewing their pain on a daily basis. It's mostly monitored hourly for the first 4 hours when they're starting on PCA, then it's monitored every 4 to 6 hourly. But if the patient is more unwell, then obviously this is monitored obviously more closely as well. And ensure we have regular antihistamines, have antiemetics, laxatives, and also naloxone as well, to make sure that these are the kind of things that when patients are on PCA, you may come across with that they may be over sedated, so they may need to have naloxone straight away. So here I've put just an example of the PCA dosages that we use at Whittington here. So one is, as I said, it's in a pre-filled syringe, which is 100 milligrams in 50 mils. So every time the patient is having a subcap PCA, the bolus dose we're given is 2 mils in 1 mil. So they will have a bolus dose range of 1 to 4 milligrams, which is given over 1 minute. So if they're pressing the bolus PCA, then obviously they're having that kind of concentration within the 10 minutes. And obviously, if they have a continuous background, we give 0 to 5 milligrams per hour. If they have an IV PCA, for example, the bolus dose is 1 to 10, and the lockout period is 5 minutes. But this is what we use at the Whittington. Another trust, I'm sure they have a different range. And we obviously, PCAs are used here in conjunction with the pain team as well. So the pain team also go around as well here at the Whittington and look at our patients who have PCA, as well as I do when I go on ward rounds with doctors as well, just to review the PCA and making sure that obviously the patient is okay, they're fine, there's no obviously reactions that we need to deal with and so forth. And here, I don't know if you guys can, I hope you guys can see this clearly. Here is the acute pain assessment charts that the pain nurses, which we also use as well for our patients who are on PCA here. So it has to do with their pain. It talks about their nausea, the sedation. We also have a bit here, we write the concentration of how much is in. So that's what we do mostly on our daily checks with patients who are on PCA as well. We also have to, and it tells you at the bottom here how often you should be doing it and so forth as well. So this must always be implemented. And I think every trust has a different kind of pain assessment chart that they use for their patients for PCA. So it must always be implemented for patients on PCA. Then we have fluid balance. So fluid balance, a general term of it is fluid balance is a term used to describe the balance of the input and output of fluids in the body to allow metabolic processes to function correctly. It is an essential tool in determining hydration status. Accuracy in recording fluid input and output is vital to the overall management of certain patient groups. So it's very important that when patients come in with a sickle cell crisis, as well as the pain aspects that we're giving them, hydration is also extremely important. So hydration is essential in preventing dehydration. And some patients already come into hospital with dehydrations. That's why they're having a very bad painful crisis. So it's very important that we give them fluids, whether, first of all, it should be orally. And in some patients who cannot take orally, then we have to give them IV fluids. So we have to make sure that either way, the patient is drinking at least a maximum of 3 liters of fluids a day, which is equal to about 60 to 90 mils per kilogram body weight within 24 hours. Caution with patients. So patients who have cardiac issues such as pulmonary hypertension and patients who have chronic kidney disease as well, we have to be very careful when we're giving them fluid as well. So therefore, they will be a little bit different. Sorry. Patients who are also less body weight or who are quite petite and small patients as well, we have to be careful as well of how much fluid we're giving them as well. So these will obviously be titrated for such patients like this. We mostly use sodium chloride or glucose or Hartmann's fluids. And it's definitely important that we also have a fluid balance chart. Must be used all the time, regardless if the patient's on IV fluids. Even if they're on oral, you must know that obviously they're taking at least, as I said, 3 liters of fluids a day. Or if they have other, as I said, issues as well, we're giving them, the adequate amount that we should be giving them. And obviously we can see this. Doctors obviously go through it and see, okay, fine, the fluid balance charts, what they're taking in and what they're bringing out to make sure we have a right balance. And also as well, we have to also make sure we see as well, if we're asking the patient if they frequently have gone to, pass urine, to make sure that obviously they're not in fluid retention due to the strong opiates that we're giving them. So here we talk about signs of deterioration. So in a nutshell, patients who are deteriorating who come with vaso-occlusive crisis, low oxygen saturation of patients' baseline on air, as well as increased oxygen, obviously is they need increased oxygen requirement. These patients who tend to fall below their baseline definitely do need chest physio, as well as an incentive spirometer and obviously review. Because again, are we looking for signs of acute chest syndrome, or could this be a PE, for example? If they're having chest or back pain, could be a sign of deterioration as well. If they're having fever or rigors as well, are they having sepsis? Is there infection that we need to look out for? Also, as well, we need to also do a urinalysis for the patients as well to make sure if there's an infection, sometimes you pick it up in their urine. Abdominal pain as well. Are they having distension? Sometimes if we're having sequestration, which is splenic sequestration or hepatic sequestration. Sometimes abdominal pain can mean girdle syndrome, which is severe sequestration in the vascular bed, which is in the liver and the lungs as well, which is also very, very important to act upon quickly as well, because this patient needs to be rushed to ITU for exchange transfusion. Also, neurological changes as well. Are patients having any fits, numbness, limb weakness? This again will need urgent medical review. Are they having a stroke, for example? Delirium or confusion may indicate sepsis. And marked elevated, so these are the bloods as well that we do for our patients mostly. So if the doctor sees that they're having a marked elevated of bilirubin, a rise in serum creatinine, and respiratory failure, these all indicate multi-organ failure as well. So the blood as well also gives us signs that the patient is also deteriorating. A prolonged erection in the penis, which lasts over 2 hours. Some other trusts said if it lasts over 1 hour as well, is a medical emergency. But this mostly happens in men or young boys as well. Either having severe pain that's unresponsive to analgesia, including PCA as well. This could be that if the patient is not, having good response to PCA, and we've put all the interventions in for their pain management, and they're still not responding. It could be that they're deteriorating. There could be something else that's going on we need to look out for as well. And these patients, we don't normally give patients blood transfusion for just vaso-occlusive crisis, but if it gets to a point where you put all interventions with their pain relief, they're not having any other signs or symptoms of deterioration, but their pain is just not getting under control. Sometimes we may give them top-up transfusion depending on their HB or exchange transfusion, but we don't tend to really do that as a first thing. And then obviously we have to look at dark urine as well. So patients who have had top-ups or exchange transfusions sometimes do come in with a delayed hemolytic transfusion reaction. And the first thing you will notice is that we'll have a dark urine. So therefore, we need to act prompt in there as well to give them treatment. Mostly patients who are having a delayed hemolytic transfusion reaction tend to need blood transfusion. But then before we give that, we will give it, we will give methylpred and IVIG first, just to try and counteract that the HB going down as well. So these are the kind of things that we need to look out for in our sickle cell patients who are obviously deteriorating. So in conclusion, looking after patients, we have to give them prompt pain relief. We have to make sure that their pain is controlled within 30 minutes and try and control that within 2 hours if they're in A&E. Monitor sedation, respiratory rate, sats on their oxygen and their vital signs very promptly, as I said. We may also pick up things which we need to act upon, or maybe this could also be signs of the deteriorating patient who has a sickle cell crisis. We have to obviously maintain their fluids, so 3 liters in 24 hours. But if they are, as I said earlier on, if they have cardiac or renal failure, or they're quite petite patients as well, this may alter how much we need to give them in a day. And as again, if any unusual symptoms or any different or atypical symptoms that the patient may say, again, we need to act fast. And that is it. Do we have any questions? Right. If we don't have any questions, I would say we have finished our talk. And I wish you guys all a very good day.